Welcome to the Arctic Gynae Center webinar series.
My name is Dr. Agbayewa and Atoki. I'm a medical officer in Arctic Specialist Hospital. And this morning we'll be talking about neonatal jaundice, the prevention and its management. It's a very important topic and something that we've discussed before so many times. So it's just very important for us to reiterate and keep on discussing about it so that we can know how to manage it, how to see it, how to diagnose it, and what to do next immediately we were able to diagnose it. So yes, this morning, without wasting our time, I'll be following these outlines and I'll discuss about it in the introduction. I'll talk about a brief breakdown of how bilirubin is gotten, how the jaundice itself is gotten, the different types of jaundice, how to clinically evaluate jaundice, and also the different complications that can rise as a result of severe neonatal jaundice, what to do in the hospital, how to investigate it, and the treatments total. So without further ado, let's just introduce jaundice. Neonatal jaundice basically is the yellowish discoloration of the skin and is clearer, and also the mucous membrane. Now, when I say it's clearer is the yellow part of the eye. So I say the yellow part, the white part of the eye. So whenever you notice a yellowish discoloration in a child, which usually is in the first month of life of the child, and this is what we call jaundice. You notice the skin being yellow, this clearer, which is the white part of the eye being yellow, and of course the mucous membrane, that's the other part, the lips, the inside part of the mouth, you notice it being yellow. This is just tilting towards jaundice, and it's as a result of elevated level of bilirubin in the blood. So it's a very common condition. So, and it's common among term and preterm infants. But however, among term infants, it's seen in about 60% of term infants, and for the preterm infants, that's those are given birth to before the gestational age of 37 weeks. About 80% of them usually arise with this, and there's really no much. It's not the rocket science to think about. Basically, as a result of the premature development of the liver, and we'll talk about that in details. Metabolism. So the major component of jaundice that causes jaundice, major thing that is in the blood that makes this yellowish discoloration that causes people to causes children to exhibit jaundice is bilirubin. And bilirubin is a major problem. Where is it gotten from? Usually gotten from breakdown of some particular products in the body. These products are proteins, and they are usually found in the reticuloendothelial system. And then majorly, a major source of this heme-containing protein is red blood cell, which is in the blood. The blood usually comprises of different cells: red blood cells, white blood cells, platelets, so many other components in the blood that gives it its function, that makes it function. However, the key component in the blood, which gives rise to this bilirubin, is the red blood cell. So usually, the red blood cell contains hemoglobin. That's what gives it its reddish color. And apart from giving it its reddish color, it helps in transporting different other things to the body, the blood, to carry oxygen to the body, excrete carbon dioxide and other nutrients that is necessary for the body. So it's this hemoglobin that is, when it is broken down, that gives rise to this bilirubin. Now, this is a picture, just a picture that just explains totally about how bilirubin, which is the major component of jaundice, is gotten. And then, like I said, it's gotten from the red blood cell, which in this case it makes up of 75% of the components of bilirubin. So when this red blood cell is broken down, it gives rise to heme, and also furthermore gives rise to bilirubin. Now, there are two forms of bilirubin: the unconjugated and the conjugated. I don't want to bore you much with the medical terms. So I'll just go ahead with where they have been broken down. So the liver is a major part of the body that helps with the breakdown of this bilirubin that is gotten from red blood cell. There are some other enzymes that function in this process of breakdown. But however, the liver here is the major component, and like I said earlier, that once that it's more in the preterm, it's not like it's not in the 10 babies. Those are the ones that are giving birth to after 37 weeks. It's there, but it's more in the preterm because of their reduced. They are still not yet fully developed. So we understand that the liver also is not fully developed, so which could also predispose to the poor breakdown of this bilirubin. Right, it's converted in the liver and it is sent to the intestine, which through some process called enterohepatic circulation takes it back into the blood, which gives rise to this jaundice per se. Then also usually what helps in this of reduced jaundice is the more the body is excreting it. When the body is able to excrete it, that's bilirubin, either through stooling, through urination, it helps to clear out this jaundice. But once there's reduction in excretion, there's this buildup of bilirubin in the body, which worsens jaundice. Now, for the types of jaundice, we have the physiological jaundice and we have the pathological jaundice. Now, for the physiological jaundice, is a type of jaundice. Now, I'm going to say, permit me to use this word, the good jaundice and the bad jaundice, however, but not per se, not as literal as it means. Physiological jaundice, we say, is the good type of jaundice because usually it's something that is common. It's something that happens generally, mostly in children, not all children, anyways. But how to differentiate between this physiological jaundice and pathological jaundice? So physiological jaundice appears after 24 hours of life of the child. Usually is rarely seen in the first 24 hours. So after 24 hours of life, that's when you notice this jaundice, and then you notice that the bilirubin rises by about, there's a way we measure this bilirubin, and it's in milligram per DL. So per day it rises with a maximum of about 5 milligram per DL. And then usually when it gets to the fourth or fifth day of life, for children that are 10, and then we get to the peak, and however by 7th day, you notice that this jaundice value starts dropping, and the serum level never exceeds 12 to 15 milligram. And then after 14 days, clinically, it's not detected, and usually resolved without treatment. However, for the pathological jaundice, which is the bad type of jaundice now, it usually appears within the first 24 hours. So immediately after birth, sometimes you start to notice the discoloration of the eyes and the jaundice. And you know that you're dealing with something of pathology. So and the bilirubin also increased by 5 milligram per DL per day. And usually the eye level, usually the serum level is usually greater than 15 milligram per DL, which unlike physiological jaundice is usually within that range. And jaundice persists also after 14 days. You notice in the stool, you notice that the stool usually is clay colored, sometimes you see it's white colored, that's pale stool, and usually you see there's some sign of clinical illnesses in the children. And so many things that can cause this pathological jaundice, which we'll be discussing in further slides. So for physiological jaundice, there's not so much interaction. It's either there's increase in this production of this bilirubin, which usually is increase in breakdown of these red blood cells, and they are breaking down rapidly because children usually come out with a high number of red blood cells, because when they are in utero, there's no way to excrete this red blood cell, unlike the adults that we have breakdown of this red blood cell and usually excrete itself. But yeah, for children, it's not the same case. So it's either there's increase in the breakdown of this red blood cell when they come out of the body, or there's inefficient hepatic bilirubin excretion. Like I said earlier, either the liver is not fully functioning yet, and the bilirubin that is being broken down is not well excreted, and then also there's increased enterohepatic circulation, which like I said, is what takes the bilirubin back to the body. So when there is a mixture of these three components, we tend to have hyperbilirubinemia, which hyper here means elevated, hypo means reduced. So hyperbilirubinemia basically increased level of bilirubin in the body, in the blood. Now, so also for physiological jaundice, other things, like I said, enteroplasmic circulation. Also, there's something we call meconium. Meconium basically is the first stool that the baby passes out, and usually are usually concentrated in bilirubin. So when the baby is not passing out meconium, this stool contains this bilirubin. So when the baby is not passing it out, we know that okay, there's still increased circulation of this bilirubin in the blood. So now for the pathologic jaundice, which leads to the causes of which majority components of which comprise majority of unconjugated type of bilirubin. There are so many other things that can cause it, such as blood group incompatibility, ABO incompatibility, resource incompatibility, GCSPD deficiency, which is also an enzyme which helps in the breakdown of this red blood cell. Then infections such as neonatal sepsis, urinary tract infections, and prematurity. Then also cephalohematoma, which is accumulation of blood in the head of baby fetuses, usually as a result of maybe when there is an injury while delivering the baby, which usually wears off itself, increased red blood cell mass, like I said, polycythemia, then finally breast milk jaundice and breastfeeding jaundice, which we'll talk about also in the coming slides. So now let's talk about, I would have loved to, explore more on all those other courses, like I said, but I think the one that is of more concern usually tend to pick the attention of our mothers that are coming soon. It's breast milk jaundice and breastfeeding jaundice. So for breast milk jaundice, let's not confuse it. These are two different things. So breast milk jaundice in this case, breast milk is the cause of the. Please, am I still online?
Yes, sir. We can hear you clearly.
All right. So so for breast milk jaundice now, it's usually as a result of the milk itself, right? However, for breastfeeding jaundice, it's usually as a result of reduced intake in breast milk. Now, so let's differentiate the two of them. So breast milk jaundice now usually occurs in about 2% of breastfed infants, and then usually is of late onset. Now, when I mean late onset, like usually after the 7th day of life, after first week of life, and then the infants usually are usually well fed. The weight gain is fine, and there's really nothing significant that causes that you notice in the breast milk jaundice. It's just that they're having jaundice now. So for the cause, it's not well known, right? The cause of this breast milk jaundice, what is in the milk itself that causes this breast milk jaundice. Now, usually about 20 to 40% of our mothers contain of women have a particular enzyme which is called beta-glucuronidase, usually in the breast milk, and this beta-glucuronidase is one that inhibits the ability of the infant's liver to process this bilirubin. So usually, like I said, it's usually seen in about 20 to 40% of women, but it's not something that possess jaundice as a result of breast milk jaundice usually goes as high as 20 to 30 milligram per day. And then, like I said earlier, like usually the peak is supposed to be within 12 to 15. So when it goes far above this, it's something that is of concern, but not to be scared. It's there, but usually does not cause some complications like the acute bilirubin encephalopathy, which I'll still talk about in coming slide. It's a very huge complication that one should take note of for children that have jaundice. So this breast milk jaundice, in as much as the bilirubin that causes jaundice can go as high as this 20 to 30 milligram per DL, it's very unusual for it to cause this complication, which is acute bilirubin encephalopathy. And how do we manage this, right? What we do is we just, cease the breast milk, feeding the child breast milk for about just 1 to 2 days. Substitute with breast milk substitutes, which will further lead to a rapid decline, which later on in 48 hours we notice that these jaundice tend to reduce. So usually with reduction in this jaundice. So yes, that's just for breast milk jaundice, and also in future pregnancy, there's a high chance of reoccurrence. So moving to the breastfeeding jaundice, it happens for early onset and usually accentuated by unconjugated hyperbilirubinemia in the breastfed infant. So usually it occurs in the first week of life, unlike the breast milk jaundice, which occurs about after 7 days, and is as a result of decreased milk intake and also with dehydration and reduced calorie intake. So when there's suboptimal intake of breast milk, leads to increased reabsorption of bilirubin in the intestine, like we know, apart from the fact that breast milk itself will help. When the baby is not feeding well, it tends to reduce the rate at which the baby passes through. And if the baby is not passing through, which majorly is the meconium, there's this reabsorption of this meconium back into the blood, which further, increases this bilirubin in the blood. So frequent breastfeeding, about 8 to 12 times in 24 hours. Usually, we advise that even after every 4 hours, even if the baby is not looking, complaining of hunger, with the cry and everything, tries to breastfeed the child. That is, you understand, to help with the increased price of the meconium, good nutrition, and all. So that's all for the breastfeeding jaundice. So move ahead to the clinical detection of this jaundice. So to assess this jaundice, apart from the fact that in the hospital we tend to do something called the serum bilirubin level, just to check the level of which the bilirubin is in the blood. There are some other ways that we can know clinically, just looking at the baby, and we can assume the level at which this jaundice is. So once you know this jaundice in the face, which is this one that is pointed here in the face, it's clinically translates to 5 milligram per day of this jaundice of bilirubin in the blood. On the chest, translates to 10 milligram, and once it gets into the abdomen and the thigh, you're thinking of 12 milligram. Once you get to the hands and the legs, you are looking at something of 15 milligram, and for the palms and the sole also is greater than 15 milligram. So why do we do this? We usually take the infants, we check them with natural lights, because we don't want to our judgment to be clouded when using the fluorescent lights. You use the natural sunlight. So natural sunlight helps so you can observe the baby under natural sunlight. Look at the skin, the eyes, the gums, just blanch it by using a tongue to press across the skin of the baby, and then you tend to see the yellowish coloration and to know what level it is. So now, I mentioned something about acute bilirubin encephalopathy in our previous discussion, and so it's a form of complication for jaundice when it has gotten to a certain level in the blood. So when it is greater than 20 milligram per DL, it's been children that have bilirubin level above 20 milligram per DL tend to be at risk of this acute bilirubin encephalopathy. Basically, it's just the crossing of this bilirubin from the blood into the brain through the blood-brain barrier. There's a blood-brain barrier which prevents things to cross to the brain. But however, when it gets to a particular level and it crosses the threshold, it tends to enter the brain, and which can cause a very high toxic effect for the baby. Babies at this stage are susceptible to, you notice them, they have reduced activity, reduced feeding, normal reflexes they have tends to be reduced, and then it can be as worse or as detrimental as a child, as an infant starting to convulse, which is something that it's not a good sight for the parents. So that is the acute stage. That's something that happens almost immediately. But with long-term effects, once this jaundice has crossed the barrier and tends to stay there for a very long time, children tends to there's something we call kernicterus. That's the chronic effect of jaundice entering the brain, and we tend to see children having things like these infants when they grow up. They can develop some things like cerebral palsy, and then some other reduced mental retardation. In the children when they grow up, you notice that the babies are not doing, the child is not doing well in school, and then when you take them to the hospital to evaluate, they ask you questions about their childhood, if they had jaundice in childhood, because that's by and large risk factors for jaundice, for encephalopathy. So the main thing about this discussion is to try to identify it early, try to bring them to the hospital so that they can be treated immediately. And apart from the doctors trying to assess your child, as a mother, you should also know how to assess your child at home to know for if there's any jaundice at all. So you bring to the hospital and then treat accordingly. So now, going forward to the treatment. So the treatment for jaundice basically is not so complex. The moment you notice your child is having jaundice, bring to the hospital, which they're going to run some investigations. They ask you a couple of questions just to be sure that the baby has not had jaundice since and not been showing the complications of jaundice. So they take the blood sample. Apart from bringing the child when you notice it, in our hospital here per se, we do a routine blood test. We do routine blood tests for our babies after the first hour of life. Check the level of the jaundice in the body of the blood of the baby, just to be sure that our babies are not experiencing any form of jaundice. And also, in the moment we notice any increased level, we tend to take action fast. We commence them on treatment just to prevent any complications. So how do we treat now? So basically, treatment is with phototherapy, which is a blue light from a blue fluorescence. It's not the usual blue light that we see around you. There's a type of specialized phototherapy machine that we have. I'll show you a picture, and also there's the fluorescence type and there's the LED light type. So what we do is we expose the child to phototherapy. We remove all the clothing, just leave the baby on the diapers, and also cover the eyes to prevent some complications, which I'll talk about later. So what's phototherapy here is a sort of light which absorbs the bilirubin, and it converts the bilirubin from a toxic type to another type which can be easily excreted through bile. Like I said, increased excretion helps in clearing of this bilirubin. You understand? So it helps in converting bilirubin to lumirubin by an irreversible reaction, which further is excreted to the urine by the kidney. So this is just like a picture of how the phototherapy machine looks like, and it's also considered as a drug for jaundice with the appropriate dose and the duration. Also to be able to know this the effectiveness of phototherapy on a child. Usually the best light color, which is blue, the duration of exposure, that's having an adequate exposure, not exposing for a while and bringing the baby out of the light. We don't get to baby doesn't get to experience treatment. How much of body surface is exposed, the hands, the body, the skin. That also matters also. Then the light also, the level at which the light should fall on the baby in the incubator also. If the baby is in the incubator, complications of phototherapy now. There are different complications. Like we all know, almost all drugs that we have side effects. So almost similar in this case. So you notice that, but in the case of phototherapy, usually they tend to resolve on their own, without any treatment. Sometimes you notice that the baby is passing excessive stool, which is which as a result of therapy. Sometimes you notice that the baby is dehydrated because of the exposure to light. So we tend to advise our mothers to increase breastfeeding every 2 hours. Either way, whether the baby is hungry or not, breastfeed, because at that point, baby is losing a lot of water because it's exposed to the phototherapy. So we tend to breastfeed well. Then for babies that are not yet, for mothers that are not yet lactating, you can use the breast milk substitute for the meantime, just to help the baby to get the fluid that baby needs. Also, there's this form of rash that is noticed on the baby, photodermatitis, as a result of this phototherapy machine. So that also wears off with time. So to prevent any form of retinal damage, which is injury to the eye, when the baby is looking at light continuously, we tend to use a patch to cover the eye to prevent its exposure of the eye. Then also sometimes the patch also tends to cause some form of nasal obstruction. So the nurses pay attention to the baby, they come and check the baby. Also, the mother can be checking the baby to just prevent the patch from covering the nose of the baby. Then there's also something called bronze baby syndrome, and also some other complications that are preventable. So for babies that eventually fall into a level whereby the serum bilirubin exceed 20 milligram per DL, and the cord bilirubin also exceeds greater than 5 milligram per DL. So at this stage, there might not be any, the phototherapy itself might not be effective. So at this stage, what the baby needs is an exchange blood transfusion, whereby blood is taken from the umbilical cord from the baby, and is replaced with a fresh blood, usually through the blood group and cross matching. If it matches with the mother's own, you can use the mother's blood. If it doesn't match with mother's blood, find another person's donated blood that matches with the baby. So, you exchange it. But usually, it's better to prevent it from getting to this stage. So, by and large, it's better to detect it early so you can use for therapy to treat it. So, these are just the explanation of the exit blood transfusion, which basically is done with a push and pull method, and then it's done in early course. Then push, a small quantity of blood to push into the baby to prevent any form of complications of blood transfusion. Also there are some complications of blood transfusion, exchange blood transfusion this baby, like the gut perforation, wrong position of the catheter, and then transmission of some other form of infection. So like I said earlier, it's better not to get to this stage rather than looking for how to do an exchange blood transfusion. If it's detected early, bring the baby to the hospital, let's treat for the therapy and discharge appropriately. So to prevent this hyperbilirubinemia in newborns, which is jaundice in this newborn, there are some guidelines that we need to take note of, which is we have to promote and support successful breastfeeding. I've always been reiterating on, also we have to establish a nursery protocols for identification and evaluation of this jaundice, which I said in our hospital. We measure the level of this bilirubin in the first 24 hours of the baby. We take the blood sample, we notice, and we examine the child under natural lights for any jaundice every morning when the baby is in the hospital. Every bilirubin test that has been done, we interpret it according to the infant's age in hours. So we monitor babies that are less than the 10 weeks of gestation, 37 weeks, 30 weeks, depending on the case. Maybe we monitor them closely for children that pretend to see if there's any jaundice also. Then we do a systemic assessment. Then we also inform the parents, educate them on breastfeeding, the importance of breastfeeding, educate them on the importance of assessing their child every day. Also noticing the urine and the stool of the baby every day to see if baby is passing urine well, if baby is passing stool well, to increase the excretion of this jaundice. So by and large, it's good to breastfeed your child very well, about 8 to 12 times a day. Also take note of the baby also. Then we as a doctors also encourage our mothers to follow these instructions. So jaundice, generally, to recap, it's one of the most frequent cause of admission. of the infants, and then usually for physiological jaundice appears in after 24 hours of life. Pathological jaundice appears less than 24 hours of life, and also it's an emergency if it appears less than 24 hours of life and should be treated as such. So that comes to the end of my presentation. Thank you for listening.